decided I wasn't going to come back and repeat those because there's not a whole lot new that I can tell you about. But I am going to talk about alopecia areata, even though it uses steroids as its main base, because it has some interesting immunotherapy that it uses. We're also going to talk about nail fungus, which you will see a lot and a lot and a lot. Paronychia, we're going to talk about melasma. I'm going to spend just a short period of time, and then I've got something. Oh, ingrown toenail. So I know if I say this, I will curse myself, but it's a short handout. We should be done in shorter than 2 hours, but I know that that usually doesn't happen. We'll need to fill the time I've got. So I think you should get a sense from Professor Hughes what PAs do in dermatology. I don't know the whole scope of everything they would do. I don't know. Some of the treatments we're talking about today are really done by a dermatologist. Now, I don't know if you work for a dermatologist, if that's what you would do too. I just don't know. But I think it is helpful, again, I've told you this before, but I think it's really helpful when you understand therapy or things that are done to patients without you ever doing them. So I was an inpatient clinical pharmacist for 8 years before I decided to go to outpatient. I couldn't take the call and the disruption of life after a while, so I moved to outpatient. But what I found helpful that I took away from that is that I had been in the cath lab, I had seen surgeries, I had been in ICU and taken care of those patients, I had helped admitted patients through the emergency room. So I knew what those things looked like. So when patients would come out of the hospital and I would see them after that, then I could relate with them. Or I could take an x-ray and I could say, here's what they're saying, because often they hadn't seen the doctor yet or nobody had ever done a follow-up with them, and I could help interpret. Or I could understand context of what had happened to them when they had been in a certain venue. So I think that even though I'm going to teach you about some drugs that you may never touch, you may see them for other reasons in your whatever practice area you're in. So I think it's helpful to understand what they've gone through, how did they get to that point. Some of these treatments are really difficult. I think it's important to understand that so you can pick up on adverse effects. I've said this before. Also encourage patients to stay adherent, and when they're not adherent, understand the barriers they could be facing and then how to get them back on track, or how to get them out of the crack they found themselves in and back into treatment with someone. Okay, so we're going to start with alopecia. So I put the fox there because the word alopecia comes from the Greek word for fox, because, and I didn't realize this, but at certain times of the year, foxes shed a lot of their fur. I didn't know this. I think it's probably about this time of the year they get rid of almost everything, and they get very, very thin layer of fur. So that's where the word alopecia comes from. I thought that was interesting. It's just one of those freebies that you get for being in class today. Okay. So did you, have you talked about alopecia? Okay, so tell me what you know about it.
There's like varying degrees, so some people will just lose like a patch, or some can lose all the hair on their body.
Okay, so alopecia areata, makes sense. Alopecia totalis is they lose all body hair, everything. And then there's a universalis, which I think is all the hair on the head. I don't think it necessarily pertains to all body hair. Okay. Anything else you've learned?
There's some that are associated with scarring and then inflammatory processes where the areata is not.
Okay, good, very good. What causes it?
Androgen levels?
Androgen levels have been indicated, what is autoimmune disease. So they're really not extremely sure. Probably all those play a role. What else have you learned?
It can be really hard to treat.
Really hard to treat. And why is that? You're right. It's
There's
hard.
not a clear cause.
Okay, so whenever you don't know the cause, then sometimes that is part of the problem. Anything else? Long time to restore. So hair doesn't grow real fast. Didn't like those Tressie dolls. Y'all didn't have those. You've ever heard of them? Yeah. So this little doll had short hair, but you could pull on it and she would become long hair. So that was those were Tressie dolls. Okay. They probably have even better now. I just don't know. Okay, age of onset?
Young.
Young. So kids. So not unusual for it to be in very young kids and young adults. So 15 to 30 would be a very common age. Can you think of a worst time in your life to have that happen to you? Okay, so how must they feel?
Embarrassed.
Embarrassed? Very self-conscious?
I know a little girl who has this and she gets made fun of at school and it's really hard.
Very hard. Kids are hard on each other.
I grew up with someone that had universalis, just no eyebrows, no eyelashes, nothing. And now she has tattooed eyebrows and a wig, I think. She's a year older than me.
Mm-hmm.
But she was bald most of the time growing up and just wore a bandana a lot of the time, especially when
Wow.
outside.
Wow. Okay, I saw a hand back there. Anybody else? Page of onset we talked about. Oh, well, the other thing is that, the other reason for especially mild areas is that the hair grows back. So it'll fall out and then it'll just grow back. And then after a couple of years, it'll fall out again in a different place. So that's another reason why, because of the treatment, can be fairly immunosuppressive, can be very hard on people, lots of side effects. Then some people, for milder, would not treat. I find this woman's story compelling. I think she does a really good job of talking about the impact on her. I'm not going to play, it's 10 minutes. I'm going to play a part of it.
Hey guys, my name's Marissa. I am from Bay City, Michigan, and I currently live in Chicago. I just want to talk about my alopecia, my story with alopecia. Alopecia is an autoimmune disease where your hair falls out and you have no control over the way that you look. So I've been dealing with this for about 15 years. I was diagnosed in maybe the first second grade, and it started out small, and it was just like dime-shaped bald spots on my head. And I started going to the doctor, and so I had all the creams, the shampoos, the steroid shots. I used to get a lot of shots in my head to try to stimulate the hair growth. And for a little bit that stuff worked. But one of the downfalls of that is that your body can get used to the medicine. And mine did. And so it was still small spots on my head for a little bit. And then I started high school. And it just got worse. I found clip-in extensions and bobby pins to be my best friend. And I probably at one point, I had more clip-in extensions on my head than my hair on my head. And so that's how I dealt with it for a couple years. I was never bullied. by anyone. This isn't what that's about. I think I was more bullied by myself because I thought, okay, if I lose all my hair, I'm also going to lose all my friends. I'll never get hired for a job. And that was just like a young person's mind. Like, that's what I thought. And that's insane. Like, that's not how the world works. And so I dealt with the clip-in extensions for a while, and it would take me hours to get ready in the morning. And some days I wouldn't go to school because I would get so frustrated in the morning trying to cover up every single spot. So there was times where I would just cry and I'd just give up and I would just lay in bed. And I wasted a lot of days like that. Too many days. No one should do that. There's bigger priorities to worry about than your appearance. I remember when I had maybe about like 50% of my hair, and I would get out of the shower and I would blow dry my hair with my back to the mirror because I didn't want to see what I looked like because I thought like that I was ugly. And so I think that was the toughest part, trying to battle myself. I don't know what's harder, battling yourself or battling other people. But that's what I dealt with for years in high school. And I think it was my sophomore and my junior year of high school, all my hair grew back. And I thought, I beat it. Like, I'll never have alopecia again. I'll never have to worry about this again. And then when I was a senior in high school, I had about maybe less than 50% of the hair on my head again. And I would always wear my hair up, or I would, the extensions came back, and that's how I dealt with it again. So I graduated high school. A little bit after that, I met my fiance, and he was in barber school then. And I would, as soon as I met him, I thought that like I had to tell people about my alopecia as soon as I met him, so that I just get it out of the way. So if they ever saw a spot on my head, they wouldn't think something was wrong with me. So that's what I did with him, and he didn't care. Like, and so that was like extremely eye-opening. Like, someone that I was starting to get close with said that that's not what's important. I think that was, I don't know, that was just, it was good. And I started to talk to him more about eventually shaving off all my hair, like just to be done with it, to get rid of it, to finally have control. And so he's like, well, let's wait. Let's wait for a couple weeks or whatever, and if you still feel the same, I'll do it. That he'd shave my head for me. And so I waited, and then one night I decided that this was it. This was the night that I'm just finally going to take control. And so I put the rest of my hair up in the ponytail and I cut it off. And he shaved my head. And I just remember looking in the mirror and just feeling relief, like that I won. And so the next morning I went to my parents' house and they saw, and they were a little shocked because they didn't think I was going to do it. But they were supportive. And I've always had support. Whatever made me feel comfortable or what made me feel better about myself, they were all for. And I'm lucky to have that. But I wasn't quite ready to show the world, like, my bald head. And so I would wear hats every time I would leave the house. If I went to let the dogs out, I wear a hat on my head, go to the store, hat on my head. And it was like that for a while. And then I decided that I was going to move to Chicago, and Drew was going to come with me. So we moved here, and and I started to realize that there are more different people here than like my bald head. And so I started to wear my hat less and less. And I started to gain confidence that way, like, okay, people aren't just looking at me because I don't have any hair on my head. And that was a big step for me to do. And I had support then. I started working at Urban Outfitters, and the group of people that I became friends with were extremely supportive. They would let me know that it's okay to not wear a hat to work every day. That didn't matter to them. What I'm just trying to say is that the people that love and care about you don't care what you look like.
So what did you learn from her? She taught it better than I could in terms of what happened. She gave you, her journey's amazing. And I love it how she came through it. And she's very honest. So what'd you learn? Or what struck you about her story?
They used to control her.
I thought that, and you know, that is so true with most people, with most illnesses, that loss of control is very frightening. People don't like it. So they'll do whatever they can gain control over their situation. So that was her way. What else?
Just the fact that she was battling herself more than anything. I don't know if her friends actually, if she didn't spend that many hours trying to hide it, they may not have been aware of everything going on, but she definitely was harder on herself than what everybody else seemed to be.
Yeah, so keep in mind what she said about the shots in the head, because that's the main treatment is lesional shots, steroid shots. And it can be multiple ones in an area. We're limited more by the amount than we are by the number. Anything else? Do you think our doctors do all that? Providers? No. So it kind of gives you some insight into where people are at certain times and what they'll do. So keep her story in mind as we go through it. You can view the rest of it if you're interested. Okay. So back to page 2. So you got the peak incidence. Male and female are pretty much equally effective. Some studies give a slight edge to more females than males, but most say it's pretty equal. So if you look under that last bullet in the first section, it says that 50% of people who have a patchy alopecia areata, spontaneous hair regrowth within a year. And most will relapse, so it's not a one and done. Very unpredictable, so that causes a lot of distress. You heard that in her. She got to a point where her hair all was she goes, thought I was done with it, over it. So what happens, clumps of hair fall out, leaving a totally smooth, round, hairless patch, or the hair just gets thinner overall in an area. We talked about the loss of body hair as well. Hair will usually grow back, but it may fall out in an area. When the hair comes back, it's usually just like the hair they lost, but sometimes it comes in very different. It can come back different in texture. It can come back in totally white. If that falls back out, it can come back black. So there's no rhyme or reason. So you can see how it drives people nuts, and it's so visible. You know, some of the diseases we have are very hidden and no one ever knows, but that one you just can't hide it. So those are pictures of all the different presentations, the universalis, totalis, depending on either totally body hair or total hair on the head. Okay, so let's look at management on page 3. So first-line therapies, and there aren't a lot of studies, so there's not a lot of comparisons. Most of this is going to be anecdotal, what people have done, and just kind of what is traditional or conventional for treatment. So it's going to be intralesional triamcinolone, or it's going to be the application of potent topical steroids to the head. This is usually done for, the intralesional are good when you have probably less than 50%. Because the injections can be very pointed and focused, so that usually is a good place for that therapy. When you start to lose larger parts of hair on the head, maybe greater than 50%, then going to a cream, because just the practicality of injecting that much steroid is problematic. Patient tolerance for one. So then when you start to lose more than half your hair, then going to a topical steroid or immunotherapy is probably the next step. If you look under administration, the goals are to promote hair regrowth, limit hair loss. The other thing they do is you can put a topical anesthetic on the head before injection. So you can see the two that are lit down there, so lidocaine or prilocaine, either one. And they do it with the cream, and they put it on the hair and they wrap it, and they keep it on there until just before they inject. And then they wipe it off, and then they inject the head. And you see it's up to 2 hours before treatment. So they're injecting into the subcubitus, so the subcutaneous fat of the skin. Giving you a couple of pictures here to look at. So we're injecting down into this area here. You see another picture. This kind of gives you the layers, but this gives you a little bit more of the structures of the skin. So we're injecting down to that part. This shows you just they're drawing it up in a syringe, and then they go around, and it gives you some parameters of what they do. So they do small volumes, 1/10 of a cc or mil, and they inject it into multiple sites about 1 centimeter apart. So 1 centimeter is how long? 1 inch is equal to 2.54, so it's about 1/2 inch, a little less than 1/2 inch apart. Okay. So the dose and patient tolerance is the extent of the disease, patient tolerance. So around 20 milligrams is what our patient's going to receive. But note there that the max is considered 40 or less, 40 milligrams or less. Adverse effects. So this goes back to what we talked about last time. I'm not going to spend a whole lot of time on it. You can go back and refer to the notes we did from the first lecture on just general dermatology, general steroid use. So skin atrophy is the most common. It usually will resolve or revert to normal. The telangiectasia can occur, so not only have you got bald spots, but now you got the telangiectasia in there. And then hypopigmentation also can occur for those who have a darker skin. Questions on those, on injection, and I don't know if I can tell you much more, and I'd be happy to entertain questions. Okay, page 4 then. So new growth is usually visible in 6 to 8 weeks. So about this time we see hair growth if you shave, or if you get a haircut. With me, if I don't cut my hair every 4 to 6 weeks, I can't stand it because enough of it. My sister has told me, she's a hairdresser, so I can't remember how fast hair grows. It's like 1/4 or 1/2 inch, and that 1/2 inch has got to be too long. So anyway, so there's the regrowth. So treatment repetition every 4 to 6 weeks, and you can do that for up to 6 months, I believe. But they're saying that if there is no response after 6 months, move on to something else. Unlikely that you're going to get any response. So if you're not going to use an intralesional, then using a potent, so one of the higher classes, I've seen a variety of different steroids listed. in different reports. And so it looks like it's mostly the group 1, group 2. So the super high or the high potency steroids are used. So if they can't tolerate the intralesional, that would be an indication, even if it was a small area, if they won't tolerate it. Children, can you imagine having to undergo that? So in those cases, using a potent high dose would be okay. Same kind of adverse side effects that we talked about with the intralesional. Adrenal suppression, at least with the intralesional, isn't reported, but they also admit in a lot of the studies is that they don't look for it. They don't measure it, so they don't know. But some of the studies with the more potent topicals said, yes, there is some mild degree of adrenal suppression. So keep that in mind. Question? Okay, topical immunotherapy. I think this is one of the most fascinating. It's so unusual, and I would love to know who figured this out. So topical immunotherapy is interesting because what you're doing is you're irritating the skin in order to kind of counteract the allergic reaction that's already taking place in order to get the hair to grow again. So it's like I don't know what I haven't thought that far in terms of what it would be like, but you're setting up a contact dermatitis that immunomodulates. There must be something that the skin can't do both. Or it kills off those cytokines, or there are counteracting cytokines that, in the end, hopefully, your immunotherapy worked. So it's a topical prep. You won't see these agents any other place. If you look at the top of page 5, they're fairly effective. 40 to 60% of people grow back significant amount of hair. And I'm going to show you some pictures of that. The topical immunotherapy under administration are listed. These are all chemicals. You have to get them from a certified chemical company. And then either a compounding pharmacist. There are pharmacists that specialize just in compounding products. And they have to be licensed. Or they're trained, or they have, they're not licensed. Certified might be a better word. And then, or the clinician themselves may do it. But they can also sensitize the person that is developing them or making them, compounding them is the word. So people have to know what they're doing, or else they'll treat themselves as well. So diphenylcyclopropanone, it's known as DPCP. That's the way you will see it. The squaric acid dibutyl ester, SADBE, is a secondary. The first one is preferred, and it's a little bit more effective than the SADBE. The dinitrochlorobenzene, the DNCB, not used much anymore because it is thought to be a mutagen, and worries about cancer have overridden most of its use. So the two that you will see the most are those first two. Let's see. So these are usually left for people who either can't tolerate the intralesional or they have a contraindication to using a potent steroid, or they had no effect, or they've had a great deal of hair loss. So this is usually in people who've got more than 50% hair loss. Doesn't have to be though. So it's very interesting how they do this. I don't know of any other, except maybe some chemotherapy where you do similar. So what they do is they make up a small amount and they test it on the patient's skin to see if they'll react. Excuse me. So you can see down there they put a small 4x4, so 1.5 by 1.5. You can't do it on the scalp. Here they've done it on, looks like the legs of this person. And they look to see what the reaction is. If they have a huge reaction, then it tells them to start at an even lower dose. If they have an appropriate reaction, then they'll proceed and they'll put it on the scalp. So they place it on the person's head, and then they, let me go down to this one. And then they leave it on for, I think, up to 48 hours, and then they have the person wash it off. So you can see in this man's head, this part of the head was not treated. This is treated with a DPCE. And over time, you can see that the hair starts coming back in. Now, it's not perfect, but it does have a regrowth. They don't show you the, he doesn't tend to have a very irritated skin to it. But they use, if you look in your packet, so they make it up and they store it in a brown bottle. It's sunlight sensitive. That's anytime you see stuff in brown bottles, it usually means that it's a photosensitive. The product itself will break down if it has too much sunlight. And they use a swab, and like they're showing you there, they swab it over the affected areas. Now, they will start with a very low concentration compared to what they tested. And then they'll up that strength until they get the contact dermatitis that they want. So they don't want a raging vesicular reaction. So they're just going for a mild contact dermatitis. Have y'all talked about contact dermatitis yet?
No.
Okay. So an irritation, raised red area would be would be what you're looking for. So here's a couple of people who have had treatment. Again, they've done it to have, I think that probably, I don't know if they, I didn't read this backstory on this woman, if they only treated this part of her head to see, or if she just has an area of growth that won't come back. And then this is another 6-month treatment for that gentleman, or I guess, I can't tell if somebody will remember. So look under the pictures on page 5, let's just kind of walk through that. So protection of the skin is going to be very important for these folks, so wearing protective covering or sunscreen would be important. Talks about if they have severe reactions, they just back down the strength and then they work them back up. And they repeat it for at least 4 to 6 months. So you see the theme here is it's usually, regardless of whether you're using intralesional corticosteroids, topical steroids, or immunotherapy, it's about a 6-month process to get enough hair back, I think. Let's see. If it doesn't respond within 6 months, again, you would abandon it and go into something else. 40 to 60% of patients with response. That's pretty good. On top of page 6, so the side effects, so a severe dermatitis, that's an extension of pharmacologic effect. Vesicular or bullous, so great big vessels. So they're talking about washing it, using a topical steroid to treat that. Other potential side effects, and this is common, I've seen this in women who've had hair dye and they've had allergic reactions. They will get a significant lymphadenopathy all over their head, down their neck. So the same thing can happen with this product. Would not be uncommon. Urticaria, so an allergic reaction. Vitiligo, we haven't talked about yet, or I haven't. I don't know if anybody else has. So they're losing skin pigmentation. You're killing some of the melanocytes. Dyschromia, a different color. So chromia being color, dys meaning a different color to the skin than what was there before. Don't use it in pregnant women. Yeah.
Would their reaction to that be so severe that maybe it leads them to want to, like the patient themselves want to stop?
Probably. But I think that they go with such a low dose. I think it's probably unlikely. That's why it's reserved mostly for a dermatologist.
My brother had the Universalis.
Oh, yeah.
And he tried this for a little bit.
Yes.
And I think he got to the point where he was like, I don't want to do this anymore.
What made him stop?
The blisters.
Really?
Yeah, and I guess I didn't get it low enough because I feel like every week it was like awful for a few days and then go away, but.
Yeah. He may just be super sensitive.
He probably is.
Oh, goodness. Did he try the steroids before?
Whenever it started out, and it was just like the little spot they did, but it didn't really help, so.
So did they go to this very quickly?
No, it was probably a few months, like, they went ahead and let him go completely fall before they started this.
Wow. Okay, so has he ever had a regrowth after he's lost?
You know, this was when we were in 7th grade, and he still doesn't have hair, but he's starting to get some grow back, like, on top. But he still keeps it shaved just because it's not really coming on the sides. But every now and then he'll get like a few eyebrows, some eyelashes,
Wow.
like just, so I don't. It's
So
kind
how's
of
he-
bigger though.
How's he feel about it? Being a guy, does it affect him as much?
When it first happened, I think it scared him because he didn't know what it was at first. But after he found out, but just it being alopecia, he was kind of relieved.
Yeah.
Which, Peyton may be an exception, he was happy it wasn't me or my sister. So,
Oh, nice.
Yeah,
That's very nice.
yeah.
Okay, thank you. Appreciate you sharing. Anybody else? Okay, so those are first-line therapies. You got 3. So you got some reasons to try one over the other. Duration, administrations is probably one to keep in mind. Okay, so second line, so let's talk about 2 second line, minoxidil and anthralin. Anthralin you've heard about, we talked about it with psoriasis. It was the one where they put a big moat of zinc oxide around the plaque, and then they painted the plaque with the anthralin. They started with low doses and they advanced it up in time and strength. Same thing here, is what they will do. Minoxidil, it's been around for a long time. What do you know about minoxidil or Rogaine? Over the counter. So all of these products are over the counter, so your patients can try them.
I've heard that if you stop using it, your hair might fall out.
Oh, that could happen.
Like you have to take it for a long, forever.
Yep, you have to, any of these, you stop using them, the disease will keep its cycle. What else?
If you let it drip where you shouldn't, it can cause hair growth.
Yeah, that's true. If it gets where anywhere it gets, it can cause hair growth. Not everybody, but it can. So minoxidil is a very old drug. It's an antihypertensive. It's one of the old vasodilators. It's very potent. We don't use it very much anymore because it is so strong. And so you'll see some of the later adverse effects are related to that vasodilatory properties. So one of the things they found is that people who used it, men mostly who took it, got more hair. So then they, probably 20 years ago, started developing over-the-counter products. They have a lower strength for women, a higher strength for men. They recommend that women not use the higher strength, but there are women who will try it. So it is one of those things that if it works, it works, and if it doesn't, it doesn't. So it will not cause hair regrowth. And I wrote it down here for alopecia. Does not induce remission in patients with extensive or patchy. Continued application is required, which was what Amy was talking about. If the follicles have died and there's no longer present, it won't. It will not cause hair growth. So that's probably the reason for some of that. So again, all of those over the counter can be fairly expensive. So keep that in mind. Adverse effects are the ones that I more want to, one thing is that it can be used in combination with some of the first line products. So, and that has been found to be helpful for some patients. The adverse effects are the ones I want to look at. Again, Lauren said unwanted hair growth. Pruritus or dermatitis can occur. Since it vasodilates, it can make the area red, warm to touch. You can get dermatitis from that. It has, the solution has propylene glycol in it. Lots of products have propylene glycol. It's a very common additive ingredient. And it's also a common allergen. So often if people have allergies to a product, it's common to find that it's the propylene glycol that is the problem. It is not present in the foam, so if you use the foam, you get around that problem. Due to its vasodilating action, so if you vasodilate, what happens to blood pressure? New. New, all new colors, oh wow. Okay. So cardiac output is equal to what? Stroke volume times heart rate. What's blood pressure? Total peripheral resistance. Okay, well, let's go with this one. So, if you decrease total peripheral resistance, what will happen to stroke volume?
Go down
You vasodilate, then where's the blood?
in the periphery.
It's in the periphery, so your return back to the heart is down. So what happens to stroke volume?
Goes down.
Goes down. Okay? So how does the body keep cardiac output up? It increases heart rate. So if you absorb enough of this drug, then you could have those effects. Okay? So if blood pressure goes down, how do the kidneys interpret that? Say it again. Okay, so the kidneys are always monitoring volume status, right? So if volume goes down, even if you're overloaded, but the effective circulating volume goes down, the kidneys respond with what?
ADH.
Okay, ADH, what else?
Holding more salt.
Okay, so the angiotensin, renin system kicks in. And what will eventually happen?
Vasoconstriction, sodium water retention,
And what does that?
the ADH.
So eventually you get vasoconstriction and you get messages to the adrenal cortex, right, to release
Epinephrine. Norepinephrine.
aldosterone, which then has effects back on the collecting tubules to increase sodium and water retention. So used alone, a vasodilator will always, almost always cause edema in folks, okay? Because that's the way the kidney perceives what's happening, and so its response is going to be fluid retention. So you see that in here. You see the, you can get fluid retention, what else they list? Weight gain, that can come from the fluid. Hands and feet, so it'll be that gravitational or peripheral dependent edema. All of those can happen. Rapid heart rate comes from their faintness, dizziness. If you drop it enough, drop their blood pressure enough, then their brain doesn't get perfused. They perceive it as a dizziness. People are on other medications where they cannot respond to that drop. So when you vasodilate, when you stand up, what does your brain do? Notes a difference in position, clamps down on your periphery to keep blood going back to your brain so you can remain upright, not fall flat on your face. Okay, so people who are older, they've got orthostasis, they've got drugs that impair central response, then that dizziness and faintness is where that comes from. So noting the amount that they're using, how they're applying it, and the strength that they're using would all be important. So that's what I find with minoxidil. If it works, it's great, but then it's the side effects you have to worry about. The irritation to the skin, and then especially as people get older, it's the cardiovascular response that gets them. Questions about those? I do want you to know those side effects because I find them to be fairly common. The anthralin, there's really nothing there that's new. It is applied the same way, the concept is the same with using it. It is a counter irritant. It also can be used with other products. Here's a woman who has initiated an anthralin, she's using anthralin cream. And you can see the irritation that is occurring. I couldn't find a follow-up picture to see how she responded. Again, it would be second line agent behind the others. On the top of page 7, let's see if there's anything that remember about the staining of clothes and skin. The length of time to evaluate is 3 months, just like we've seen with the others in that 3 to 6 month range. We're looking for a mild irritation, not a significant one that they mentioned there with erythema and scaling. Vesicular, we don't want it that strong. I'm going to finish up here and we'll before we get to onychomycosis, just finish this. Lots of things have been tried. I'm just listed there for you to see. So you could use systemic corticosteroids. They're not recommended, especially can't use them long term. And a number of agents have been used. If you look down there, capsaicin, platelet-rich plasma, recombinant interleukin-2, hydroxychloroquine, the Janus kinase inhibitors. We talked about them with rheumatoid arthritis, simvastatin, botulinum toxin, lots of things. So what that tells you is that people get small experiences with these, see them, find them, maybe it works in their practice. There aren't big studies to undergird them. So I would say you don't use them. You stay with the ones that have some data behind them at this point. And you can see they've used some of the more potent immunomodulators under refractory cases. Sulfasalazine would fall in there. We've talked about that with RA, methotrexate, cyclosporin, azathioprine. So they're trying to modify that immune system. But those are big guns. Okay. All right, let's take a break. We'll come back about 10 minutes.